Today we'll talk about acute bronchitis. Acute bronchitis is an acute self-limited inflammation of the trachea and major bronchi. The cough lasts about 1 to 3 weeks, and there's no evidence of bronchial consolidation or underlying cardiopulmonary disease. So clinically diagnosed an acute cough with or without phlegm, and they may be short of breath and wheezing. So normally they are viral in nature and referred to as in a group of URIs, but the definition of acute bronchitis is an inflammation of the lower respiratory tract. I know that's confusing, so they're in this category of upper respiratories, but clinically they're considered a lower respiratory tract. The epidemiology, the cough is the most frequent reason for primary care visits. So about 8% of primary care visits are related to cough. Upper respiratory infections and acute bronchitis account for 60% of every cough diagnosis in the United States. Affects about 5% of the population annually, and symptom relief is primarily the reason patients seek care. And interestingly enough, the cough is so severe, they come into the office or make that appointment that first week of symptoms. The average patient misses 2 to 3 days of work because of acute bronchitis. There's higher incidence in the fall and winter, and environmental factors can increase the incidence. Viruses account for 85 to 95% of cases of bronchitis, and within the 3 top pathogens, influenza A and B, parainfluenza, and RSV are the causative agents. Less than 10% of bronchitis is bacterial, and these occur in persons with chronic health problems. Typically we see Bordetella, pertussis, Mycoplasma pneumoniae, Moraxella, Catarrhalis, and Chlamydia pneumoniae in the bacterial bronchitis diagnoses. The pathogenesis is the pathogenesis reveals that the causative pathogens rarely identified, and one of those reasons is because to collect a sputum sample on a ambulatory person is usually just contaminated with multiple oral flora, so it's just not necessary in most cases. The cause of the cough, though, is multifactorial. There's edematous changes in the mucous membranes of the tracheobronchial tree. The epithelial cells become damaged, and then there's this release of pro-inflammatory mediators, and all this increases in the symptoms of acute bronchitis. Unfortunately, there's also destruction of those bronchial epithelial cells that line the entire respiratory system, and the loss of ciliary function. And those are the same processes that occur with the common cold virus, but can be very extensive in other situations, like with Mycoplasma pneumoniae or influenza. 40% of persons have airflow obstruction and bronchial hyperresponsiveness. And really the symptoms are dependent on the anatomic distribution of pathogens. So there can be some cases that it's much more extensive. So what's the clinical presentation, and what are we going to find in the physical exam? Well, we're going to find a person with a cough with or without sputum production. That's the most common symptom. The mucus is clear, so there's clear mucoid sputum when it is productive. 50% of the patients report a productive cough with purulent sputum. Results not from really the bacterial infection, but from the sloughing of the tracheobronchial epithelium and those pro-inflammatory cells. So what we talked about earlier is really why some people can have purulent sputum, but it is not because of a bacterial causation. Cough can create an inspiratory substernal burning pain, so they might complain of that. There's nasal and pharyngeal symptoms, but they resolve pretty quickly, about 3 to 4 days. But the cough remains prominent and progressive, and big range, 10 to 20 days. But unfortunately, some people can experience a persistent cough for 5 to 6 weeks. Sometimes you'll see a low-grade fever, wheezes, rhonchi, coarse rales may be present. Vital signs are almost always normal. And when FEV is measured, that forced expiratory volume, that's that forced expiratory breath in 1 second that spirometry can measure, it can be reduced 40 to 60% in patients with acute bronchitis. So what are the diagnostics that we normally do? Usually there are no tests required for the diagnosis of acute bronchitis. When there's a cough and the vital signs are normal, there's absence of tachypnea, tachycardia, rales, or egophony. Really, there's nothing that provokes you to move further. But if they are present, those symptoms, signs and symptoms, then you might consider a CBC with a differential, so we can look at those red and white blood cells and all the differential in the white blood cells, looking at viral versus bacterial influences. Nasopharyngeal cultures can be obtained, and we would be looking in that case really for pertussis or influenza, and then a chest x-ray, and you could order a posterior or a lateral in the suspicion of acute bronchitis to exclude pneumonia. Management and treatment, really the mainstay of treatment is symptom management. 85% of the people improve without any treatment. And you have to keep in mind, even though 85 to 95% is viral, there is that 5 to 10% who have bacterial pathogen. Antibiotics are discouraged for acute bronchitis because of resistance, overuse, and they really, there's no evidence they help whatsoever. Antitussive therapy is usually prescribed because people are desperate, but the evidence on that is really weak on how helpful it is. But when we do prescribe antibiotic, if we suspect pertussis, that whooping cough, remember, isolation should be started on the day that treatment is started and for up to 5 days. And when you're considering pertussis as highly suspicious, you want to think about macrolides being the first line of therapy for that. Most common pathogens isolated in acute bronchitis, the most common pathogen is influenza. An antiviral can be effective if it started early. I think the brand name's Tamiflu. There's a couple of other choices. Because pneumonia is the third most common cause of cough illness, it must be excluded. That's why it's so important to really be able to differentiate and use your clinical reasoning between, does this signs and symptoms and presentation make me consider pneumonia? And then you look at the patient individually. Do they have multiple comorbidities? Are they a smoker? Have they had pneumonia before? Are they vaccinated? But I want you to look on pages 419 and 420, and I want you to read that whole management treatment regime, just so that you'll feel comfortable with what the evidence says on what are the symptomatic treatment choices. So when do we refer? Well, if acute bronchitis doesn't respond to symptomatic treatment, or if it lasts longer than 2 weeks, it really might require a physician referral. Just depends what your resources are and the whole patient scenario. Patients who have progressive shortness of breath, O2 sats less than 90, and signs of sepsis, needs emergent evaluation and hospitalization. Patient and family education include reassurance, and it's really important for them to understand the modalities of treatment for acute bronchitis. Reassure them that the cough usually lasts 10 to 14 days, up to 5 to 6 weeks. You want to emphasize that antibiotics are generally ineffective and not necessary. They need to rest, increase their fluid, use moist air via humidifier or shower. If they smoke, smoking cessation is a huge part of our education for them. And interesting, CDC has published some information about the overuse of antibiotic in acute bronchitis, and they suggest that we as providers Not say, oh, you have the diagnosis of acute bronchitis, but instead use the term chest cold. I'll leave that up to you if you think that simply somatics or would help. I typically have sophisticated patients who would say, oh, are you talking about acute bronchitis? But I understand why they're trying to promote that to reduce the antibiotic use. Thank you for your attention.